Good evening, everyone, and welcome to tonight's webinar on emergency medicine in general practice during a pandemic. Firstly, I'd like to recognise the traditional custodians of the land and sea on which we live and work. We pay our respects to the elders past and present. For tonight's webinar, you will see your control panel located at the bottom of the presentation screen. If you cannot see your control panel, however, hover over your cursor over the bottom of the shared presentation screen and it will appear. We have put everyone on mute to ensure the learning will not be disturbed by the background noise. Please chat to us via the question and answer box. We will try and address your questions as they come in. Tonight's webinar is eligible for 2 CPD points, which can be self-recorded. Self-recording is quick and simple, and the relevant form is on the RACGP CPD dashboard. Simply log in, go to My CPD dashboard, then quick log, and you will be able to log your points there. If you have any issues, please contact RACGP for any support in uploading this. Tonight's presenters are Professor Hugh Grantham, Clinical Education in Emergency Medicine and Resuscitation, and Dr. Emily Kirkpatrick, Deputy Chair, RACGP, SANNT and SA Health COVID-19 Liaison Team. I'd like to now hand you over to both Hugh and Emily.
Thank you, Angelica. So here we are on a Tuesday evening, ready to discuss all things emergency, telehealth, and how they all fit in together. And we're so delighted to have with us Professor Hugh Grantham with us, because we know that he is an expert in this area. So we're happy to ask him our GP questions. So please post into the Q&A box if you do have any questions at all, and we'll try and answer them as we're going through. But certainly we've got a few things to go through tonight. We've got face-to-face consultations. Is it business as usual? Well, some would say it's definitely not. We've got management of emergency presentations in COVID and general practice, and how do you deal with an emergency in virtual consultations. We're going to talk about the collapsed patient virtually, and then also about the collapsed patient in front of you and what that means from a PPE perspective. We're going to talk about paediatric assessments as well via telehealth. So, and I'll be answering the Q&A as we go through as well. So we'll go from there and we'll hand over to Hugh.
Okay, well, we thought we'd just have this as a bit of a conversation between the two of us, and you can then join in with questions. So the first question we got is this: face-to-face consultations, is it going to be business as usual? Well, at the moment, obviously they're different. They're constrained, you want to keep your distance, and so you think of things, well, of course I would love to do a fundoscopy, but I don't feel brave enough at the moment. So where does it actually change is an interesting question. Now, in emergency medicine, so that's where I want to be, we spend a lot of time with close face-to-face, and we get a lot from the look, the feel, the reaction of the person, all of which is a lot more difficult doing it in virtual space. So is the face-to-face conversations that I'm having, are they the same? I don't think they are, because I don't think I want to get that close. I don't want to shake the patient's hand. I don't want to make physical contact. Does that matter? Am I losing anything by doing that? And what did I gain by shaking somebody's hand that I don't have now?
Yeah, it's quite an interesting concept, isn't it, really? Because I know I've certainly been in the habit. I used to always shake everyone's hand when they came into the room, and that would be your way that you would build a rapport, you'd maintain that eye contact, and then, you know, you sit down and proceed with the consult. And it's very hard to do, particularly if they're a new patient on the end of the telephone, to know what their underlying story is, or their agenda is, or what they're calling about.
Think about the emergency clues you get from shaking a hand.
Yes,
is it sweaty? Yeah. Is it sweaty? Is it trembly? Does it have a firm grip or a weak grip? You sneak your hand up onto the radial pulse, and you already know what the heart's up to. And if you actually feel the pulse, you've got a damn good idea what the valves are doing. all from the handshake. So we haven't got any of that. So we're going to back off that. So how do I get that sort of information? And you can actually get an awful lot just from sitting back and watching. And this is the art of looking at somebody, looking at the color in their face, glancing down at their hands and noticing whether their hands are white or whether they're pink, whether the veins are dilated or not. Looking at their neck, you can see sympathetic tone with people who color up beautifully. You can see venous pulsation sitting up in the neck, and so if they're sitting bolt upright looking at you and you can see a neck vein, you've got a problem. So it's actually a case of stepping back and being conscious of what I'm looking for and trying to make up the gaps that I could have had from the more casual bits. And it's that conscious thinking about it. Now, the question is it going to go back to where we were or not?
And that is a really tough thing to know, because we know about 60% of consultations are telehealth currently at the moment. And certainly we're finding that people are saying they love having a telehealth consultation in terms of the community perspective. It's easy, it's convenient, you can just wait in your virtual waiting room and then be seen. But we do know that some GP consults are only using telephones for their consultation and not face-to-face virtual through all those different methods, Skype and things like that. So it does make it a little bit challenging. How do you pick up the respiratory rate over the phone without a visual look at the patient? And so I guess it's going to be thinking about in the future, what patients do we triage for telehealth, if that's still an MBS item? Or is it, you know, thinking certain things for telehealth, certain things for a face-to-face consultation? And certainly from tonight, what we're really trying to focus in is the emergency side of things, and sort of how do you triage that on the phone when this is the options that we've got at the moment, and we know that we don't have endless supply of PPE to give to our staff and to our patients.
So let's move on then, and let's talk about a specific one. So let's say we're doing a remote consultation. It can be telephone only, but perhaps you've got vision as well, which would be nice. And my patient's got chest pain. Now that's not uncommon. And therefore I'm going to put it as an emergency, because we've all been taught that, okay, chest pain, do not pass go, do not collect 200, must have a troponin, must have an ECG, it's an infarct till proven otherwise. And that's really good sound medicine. But is it always right?
No, and I mean, it's quite interesting. So we've had the international quarantined passengers who flew in from overseas, have been in the hotels, and so we've had actually quite a large number of passengers who did have chest pain in the hotel. It was quite hard, particularly for the GPs, to be able to understand over the phone what was going on in that situation. And surprisingly, a large number of those chest pain presentations were anxiety based. The fact being in quarantine in an isolated room, often without any airflow at all, was quite an anxious, anxiety-provoking event. But we had to then send I think we sent 3 or 4 people off with chest pain to ED for further investigations, because we couldn't make that differential over the phone and work out what was wrong. And so then it was really taking a very long history, and then it would be escalated up different pathways, and then I'd hear the end story at the end and say, well, what are we going to do, Emily? And we'd have to come up with a plan in conjunction with SAS and organised transportation and all of those things, because we just couldn't work it out in the end when we knew nothing about a lot of these passengers and had no past medical history. So, and in fact, one did have a non-STEMI, so we did the right thing. 1 out of 4 transfers ended up being actual cardiac.
Yeah, well, I mean, that's why we have to treat chest pain seriously, and this is why it is the great mimic. And plenty of people have real dinky infarcts without telling you about the elephant sitting on my chest. The toothache, the earache, the back pain. So it's the really, really good history is the first point. And be careful about that. But you've still got people who have had chest pain for 4 days. It is still here. And I've got this pain, and no, it's not exertional. It's been constant for 4 days. Now I come to think about it, it does hurt a little bit when I breathe in. So maybe we have to start thinking and actually backing our clinical judgment a little bit on some of these. because if you have a no downside to always playing safe and always saying go to the emergency department, and that's the position we were happily in, with no downside, then fine, let's always go for the safe. But this is the interesting question. Are there any downsides in actually sending a patient to the emergency department? You've already talked about the logistical embuggerance of getting them there safely. So that's ambulances, isolations, etc. Then you've got, if that person did have an infection, you've now given them a perfect avenue to spread it to lots of others. But now think about the person who doesn't have an infection and doesn't want to get an infection. If we are sending all our query infected cases to EDs, and I'm looking at a patient who's got a really bad chest, is on home oxygen, but they ticked the chest pain box, because they do, and they're sitting in the next door cubicle to somebody who we're doing droplet precautions and we've just done the COVID swabs on, is this a really good thing?
And that might be why we've seen a drop in our ED presentations that are now coming back up now that we feel a little bit safer in the community. But it's a really good point, isn't it? I guess it's thinking around what other avenues are there for GPs to be able to support this patient in the home environment or investigate this patient in the home environment. And so I guess we've talked about, you know, how can you do that over the phone, I guess?
Okay, so let's think about this chest pain patient that we're not sure about. And we take the history, and it doesn't come up positive for the elephant sitting on my chest type obvious history. It's just a bit vague. Well, what am I going to do with that one? Let's start with, are they actually dying at the moment? So let's have a look at them from a cardiovascular point of view. What color are they? What is their respiratory rate? That says, so if they've got a normal respiratory pattern, that says they're not acidotic, therefore they're perfusing well, or they have perfectly functioning lungs. But you tick both of those two straight off. If they look a good color, that's nice. If you've got a phone, you ask them, and you preferably ask their partner in the room, does he look his normal color, or does he look a bit pasty or a bit blue? And most of the public will give you an answer to that. So now I've got a feeling for how we go in cardiovascularly and respiratory, just from the respiratory rate and the color. You can often get people to take their own pulse, and a huge number of them have got electronic pulse devices. An awful lot of people have got blood pressure machines at home. They're of mixed value, but they're there. And maybe we can use those. So we can start to get an assessment, but it still doesn't tell me that I don't have an infarct yet. All I know is that I don't have cardiogenic shock. Okay, so I've got a bit more time, but time is muscle. Here I am thinking, well, I still haven't excluded it. What would I do with this patient? Well, if I saw this patient in an emergency department and they were safe to come in and they were not afraid, etc., I do an ECG and I do a troponin. Can we bring the ECG and the troponin to the patient? Is that possible? Is there a safer place they can get an ECG and a troponin done? Because if we've got a normal ECG with no change from the one you've got on file, and we've got a negative troponin, all we then need is another set at 3 hours later, and we're feeling much more comfortable about it. And that's what happens to an awful lot of chest pain patients. So let's think of, if they're not actually collapsing at the moment, then where do we go? You know, have we got that time? So let's think about how else we can get us an ECG and a troponin with a safer risk to the patient. What do you think about the ECG and troponin being done in your surgery rather than an ED department? How does that fit for risks versus benefits for patients and you?
Well, I guess by now you've actually screened the patient, haven't you really? You've found out that they don't have a temperature, they don't have a travel history, and they've got no contacts at all with anyone who's got COVID. And you're thinking to yourself, well, how am I going to be satisfied that I've done what I need to do for this patient to make sure they're safe and they can stay at home? So certainly if you did have the option, you could bring them in. You've assessed them, you've said that they're low risk. You're going to, when they come in, you're going to reduce the amount of time you spend with the patient so that it's less than 15 minutes. You're going to socially distance yourself, and hopefully you don't have a waiting room full of other people as well, so they can call up the practice when they arrive and then come through to your treatment
Or
room.
wait in the car till you're ready.
That's right, and then come through and have their ECG performed, read the ECG, feel comfortable that it's okay. But then you've got the next problem of what if it's not okay at that point, or then you've still got to send them on, don't you really, to make sure that they are safe.
Well, it's a case of which ones warrant the risk of going to an emergency department. So if I've got my patient now who's got ECG changes and I'm not happy, then you say, okay, there is a small risk you might pick up something going to an emergency department, but on the balance, it's worth it. There's something to be gained here. So it's this interesting balance of when do we send to an ED, when don't we send to an ED? And the patients are voting with their feet a lot here. And so we've seen ED numbers go down, and anecdotally, many of us are commenting that what we are seeing turning up at ED is sicker because they've been hanging off longer. I don't know when any of you last saw florid pulmonary edema with the pink frothy sputum. I haven't seen it for years until just recently.
So that is quite concerning, isn't it, really?
Yeah.
And hopefully they would think that they can call up their GP and have a telehealth consultation and say, look, I'm not feeling great, or a family member would call up on their behalf. But that certainly is concerning, and we don't want that, do we? We don't want these patients turning up sicker in our EDs.
So they're actually, the patients are quite afraid to turn up. I think the fear is now wearing off, and we'll probably get a rebound. But this is the phase we've gone through. So anyway, that's chest pain, and that what we thought was a nice common one to deal with.
Yes, and we also could think about whether we'd send to a priority care centre as well. And now that GPs can refer directly to one of the 4 priority care centres, and we've put out some information on that as well.
Guess what? We could get an ECG and a troponin. And that's all we really wanted.
That's right.
And I guess the other thing is, but I'm not that confident with reading ECGs. Shouldn't this do to a cardiologist? Well, the answer to that one is, you got a mobile phone, take a picture, send a fax, send an SMS. I know various people talk about us sending clinical information over the web, but
times have changed.
I think that the attitudes are getting more relaxed on that. Okay, so let's go to the next area.
Now, we did have a question come through around patients opening up a little bit more actually on telehealth, and perhaps being a little bit more honest with their symptoms or their presentation, because they don't have that barrier of looking at someone directly with eye contact. I know I sometimes stare patients down a little bit, and I do think, gosh, stop looking so much at the patient, Emily. But I think, you know, it is an opportunity for people to reveal problems, and I've certainly seen that on social media that, you know, GPs and various groups have said, I've had patients tell me things that they haven't told me for years.
So maybe there is a definite silver lining in all this. I don't think it's going to help me much with the emergencies, but
probably
it is
not.
Well, it's, yeah, I'm thinking more in a pure general practice days, but it's, you know, the oh dear, I want to talk to you about my sore foot, but as soon as mum's out of the room, can I have the pill? You know the one?
Yes, so it does provide us with that opportunity, doesn't it, to really broach some of those topics that people may not feel comfortable talking about in a face-to-face setting. All
right, so now I want to talk about what happens if we have an emergency during this virtual consultation. So here we are, and we'll still take our chest pain patient, and they're not ticking the good boxes. They are saying, yes, I've definitely got exercise-induced chest pain. It's really, really bad. And all your warning bells are saying infarct. And now I've actually got an emergency, but I can't get to the patient because If I saw that person face to face, I'd be lying them down, I'd be assessing what their perfusion is, I'd be slipping a line in, I would have called 000, and I would have gone straight, you know, ECG and straight to the cath lab is what I'm hoping for. How are we going to do that from their home?
And what if you don't know their home address as well, is the other thing. Gosh, that panics me, particularly if they're a new patient and you don't have all of those important patient information, details and identifiers, then you're in a bit of strife.
So we need to be able to quickly get, and so people would think about, let's do the logistics first, and let's make sure we do actually have a callback number and a where to get you address before we even get into it. 2 people have raised a hand there.
Yeah, so we have had a few questions about troponins, but we'll get to them in a tick.
We'll click back. Okay, so the question now is, I'm worried about my patient, but they are remote from me. What can I do? And this probably is the time where you do say, right, default position, dial 000, this is what the ambulance is for. Doesn't necessarily mean we actually committed to going to hospital. The patient may have strong views they don't want to go to hospital, either because of patient choices anyway or because of fear. But it now gets you a health professional on site who can talk to you. So remember that you can have a conversation with the paramedic, and between you, you've now got eyes, ears, and a sense of smell on site. I throw that sense of smell in there because who remembers walking vaguely onto a ward and saying, okay, where's the melena? Where's the GI hemorrhage? You don't need anything more clinical than that. You know which ward
with you, doesn't it?
So yeah, there are things that you don't get down the phone.
And I think that's a really good point, that you do have SAS that you can call up the ambulance. They can go out there, they can run the ECG and be able to provide reassurance if it is a completely normal ECG and the other history reveals itself or other things present itself in the meantime to SAS
and
as well.
They are encouraged to share. So the idea of saying, and please call me when the ambulance gets there because I want to talk to the paramedics, is a good one. And if they escalate it up to their extended care paramedics, as many of you will know, they actually spend a lot of time getting a really clear history, and then they will give you a really good feedback, both real time and written later, not just a scrappy case card. So, well, case cards are good, but you know, they do a full letter and everything.
Yes.
All right.
So I guess in terms of, you know, if we've done the ECG now, so either the patients come in the first scenario is come into your clinic, you know, because they were having that sort of low, sort of dull, achy chest pain for 4 days. If they've come into the clinic, you've done an ECG on them, or, you know, they've had the consultation in their home with SAS coming and seeing them. If the ECG is normal, what sort of value does troponin add to those low cardiac risk patients? That's a question that Mark's posted.
Okay, so what we're talking about is the non-STEMI. An ST elevation myocardial infarction is the barn door, and that means that there's a big lump of muscle that's dying. They're obvious. The non-STEMI can have subtle ECG changes, perhaps a little depression or a little T-wave flip, or worst of all, no ECG changes. And so your troponin is going to be your differentiator for the non-STEMI. Unfortunately, it's not a pure test. There are things that throw your troponin up anyway. Renal failure and many other little things will throw it up. So ideally, I want to know what the troponin was on this patient before. But if they're a chronic type patient, they may well have had troponins before. So if I see a line, I go back to the test results, less than 30, less than 30, less than 30, 35. At that point, I say rude words, because it's just enough to be, sorry, you do not pass go, you do not collect 200, we're worried.
Yes.
And you must have the second one at 3 hours to clear.
Yes, and the other thing is our rural patients who, you know, won't necessarily have access to troponins as well. So I guess that's taking into consideration.
I'm going to say the rural guys are through the rural hospitals are often very much better off because they have point of care troponins and they have ICARNet, which is their tame consultant cardiologist on a phone. And the performance criteria there is you make a call and you're supposed to get an expert call back within 10 minutes. So I think all credit to iCarNet. I think they actually we have a very good rural system there. The point of care testing for troponin is the one thing that we might look at spreading out and investing in if we were going to try and do medicine differently as a consequence to all this.
And I guess that's the thing as well, that in those settings, then you're probably more likely to bring that patient into your ED or into your clinic that's based within that hospital facility if you're in a rural area, rather than saying we'll send out the SAS. Obviously that's not going to happen in those settings. It's going to be more so coming in.
Yeah, a rural setting has got a huge advantage. I mean, the ED is not going to be jam-packed, and the patient's fear factor of picking up infection is going to be much, much less. Because they are in their own tiny community. And frankly, they are safer there because you know the community well.
And just in terms of the troponins as well, we often say in general practice, look, if it's 4 o'clock in the afternoon and you're worried that the patient's there, how are you going to be able to follow up that troponin? Because we know that a lot of GPs do work part-time, don't do after-hour work. So how do you then follow that up? And then that might be then thinking, well, I'm going to send that patient to ED. I don't feel comfortable that I've got the tools to follow them up after hours. So I guess that's also thinking about then what value does the troponin add in that case. You know, are you reassured that you've got a normal ECG, but they've just got this dull continuing pain, or are you thinking at that stage too that you would send them into ED? 4 o'clock Friday.
I'm sorry, 4 o'clock Friday, we've still got to be safe, and you still need both. You need a clear ECG and a clear trop to be happy. You don't bother with the trop if you've got the ECG that is screaming the answer at you. But I'm afraid we do need it, and we do need to work out a way to get it followed up. And again, here may be a place where we may change some of our practices. We may work out other ways to get that follow-up to happen. And I do get rung by pathology services every now and again because somebody's pulled up an abnormal result and we thought you ought to know. So if the lab's still processing it, what's wrong with leaving your mobile phone? And that's actually good care, and the lab is not going to abuse your mobile phone number, and you are going to know what's happening. Think about it. I mean, it's a personal choice, but I personally would do that. The other thing we're thinking about here is, so we're debating what we're going to do with them, and we're thinking of ways to get treatment to the patient. We've mentioned extended care paramedics, we've mentioned ordinary paramedics. We've also got various hospital at home type programs going around the place, and they are taking off. There are all sorts of little variations on them there. Usually they are kicked off and negotiated out of the hospital and therefore out of the ED department. But a phone call to the ED department may well identify, yeah, we've got a system, we've got someone who's going to be in your area, we can do that. And so we can actually have the information, you can have the discussion with the ED staff without actually having to put your patient in harm's way. So there are different ways of thinking about that one.
And we've had some really positive comments coming through around how it's often easier to access a cardiologist in rural areas than it is in the city, and a few comments around how great it is with troponins and being able to have the ones on site in many of these facilities with point of care testing has been available for a number of years now. Is there any value about the 3-hour troponin? You did mention briefly about 3 hours.
Okay, so the story here is that troponin obviously is released from muscle, and cardiac muscle with a specific test that we do, and it's released after damage. So the theory or the worry would be that if I've damaged my heart muscle and there hasn't been time for the troponin to rise, then I may miss the info. So if I suddenly get chest pain now, and you do a troponin in T plus 30 minutes, because everything's worked very, very slickly, it may not be up yet, which is why you say the 3-hour wait. Pragmatically, if the chest pain has been identical and hasn't changed for 4 days, then you wonder about the following the rules and doing the second one. It becomes less logical.
Yes, that makes a lot of sense, doesn't it? It's really is for those acute settings and seeing if the pain is acutely come on.
Plus, the other thing is, if you got one with that's up, and I want to know whether it's going up and changing, or whether it's chronically up because you've got some kidney disease. So again, two of them help me there. And so the standard process and protocol that we would do in an emergency department is a couple of them separated. And we've looked at high sensitivity troponins, bringing the gap down to an hour, and there's some research work being done on that as we speak. But the classic is about 3 hours.
Thank you for that. And in terms of cardiac muscle, we've had a comment come in around, doesn't cardiac muscle become de-innervated after a couple of days of ischemia?
If you've got, let's think this through, if you've got an infarct, the infarct itself doesn't hurt once the muscle is dead. And those of us who have a little more grey hair and remember cardiology back in the days when it's so sad you've had an infarct, have bed rest and morphine, will remember that the pain used to go away because the muscle died. So I think that's what we're thinking about. It's what we don't want to happen, but it used to happen.
No, we don't want that, do we at all? We've missed it.
It used to happen though. All right, shall we go on? Okay, so we're talking about time critical things here. And this is the virtual space. So we talk a lot about the heart, it's critical there. Now let's talk about the brain. We know that strokes are incredibly debilitating, and we know that if you use the window and you've got about 4.5 hours, you can give a thrombolytic and you can turn somebody from being a totally dependent hemiplegic, very unpleasant place back to a normal. So that's a huge benefit. That's the positive spin. Negative spin is that you're giving a thrombolytic to somebody whose brain, once you've ruled out the hemorrhage, is becoming soft and degenerate and more likely to bleed, which is why at 4.5 hours, giving the thrombolytics does more harm than good. This is why this is your outside window for thrombolytics. The other maneuver is go fishing for the clot, which is done just a little bit now, and I predict will become more and more common as the neurology follows the cardiology in their approach. But at the moment, it's the exception, not the rule. Okay, so I've got the consultation, it's happened down the phone, and looking at my wife, and she suddenly, her face looks funny, she doesn't talk to me. When did it do it? It did it 30 minutes ago, and I've just rung up. Great, we're in the window, move. That's one that we need to go straight to one of our stroke centres. So that's Lyle, Ra, Flinders. And they are going to get rapid assessment. They'll get a CT done, and we'll hold the CT for them. So they go straight in, we'll do the perfusion scans, and if positive, we will get the thrombolytic in. And they will probably do, I don't know the exact figures at the moment, but let's say they might do 5, 6 or 7 activations before they get one that they can treat. But there's such a huge prize for it, it's still worth fishing for this. That's the positive. The negative is that you are going to get people who have bad reactions to it, and you will get a high death rate, which is why initially people were really cautious about this. And there was a bit of a divide between some emergency physicians and some of the neurologists and their enthusiasm for it. But I think it's now here, it's now proven, so we need to move. Okay, so that was my stock standard, easy. How about a more subtle one?
Which is probably the ones we're going to be having who are pre-booked in, you know, for their telehealth consultation the next day, haven't disclosed that on the phone to the administrative staff. So yes, what are we going to do in this case, Hugh?
Yeah, I've got just a little bit of my memory's not got right today. I couldn't remember my daughter's birthday, but I'm speaking okay, I'm walking okay, and yes, thinking, is there something neurological going on? Is this somebody who's just psychologically overloaded with cognitive overload and they've lost it, which we all get? And this is where it gets much, much harder to assess, do a neurological assessment remotely. The only things I can comment is that we do have a couple of neurological tests that are actually very, very sensitive that don't require you to be in the same room. The first one is the walk test. Get up, walk. Can you do heel to toe and walk back to the computer where I'm watching you? That's a really, really good test, because you've got muscle power, you've got coordination, you've got balance, you've got cerebella, all of that in that simple test. If they get really good at that one, it's okay, now shut your eyes and see that they sway. Might be nice if you had someone to catch them. But what I'm saying is that in that one test, you've got a lot of neurology. You can do a quick cranial nerves remotely. I want you to look at the top of the screen, look at the side of the screen, look at the bottom of the screen. That's 3 cranial nerves gone. Smile, there's another one. And you're listening to me, there's another one.
And then I can just imagine the patient at the end's going to stick up their rude finger at you and go, shut up, I've had enough of this. And then you've tested something else.
Yeah, sense of humor and whatever. But what I'm saying is that you've got a neurological assessment there that you can do down the screen. And then last one is that don't forget that the subtle stuff is higher functions. There's nothing stopping you doing serial 7s and spell word backwards and all that sort of stuff down a virtual. So again, we can do that. So what happens if I'm now getting just a few positives on that? I've got maybe a small CVA. I'm not going to say TIA anymore because it's not trendy anymore. They're all strokes until proven otherwise. So I'm going to have to think about that. Or have I got a stroke mimic? Have I got a migraine? Have I got a diabetic? They're the 2 classic ones. So is there a migraine history? How are you going to deal with that? Quite a lot you can do for a migraine by remote. It's dehydration, and I'd like a dopamine receptor modifier. So I'd like some, have you got any Maxilon in the house? It's a fairly common dopamine drug that's around. So can we get a lot of fluid into them and some Maxilon? It might actually snap them out of it. And my standard treatment for migraine is a litre of saline and a Maxilon. No Panadol, no nothing, just those 2. And it's surprising how often that works. So for the litre of saline, they're going to have to drink it.
Yeah, it's a little bit hard, isn't it, to self-stimulate?
But
yeah,
that's that one. Next one we've got there is anaphylaxis and allergy.
Yeah, so this is the one obviously we worry about, isn't it, really?
Yeah.
Because the patient can deteriorate so quickly in front of you or so quickly on the phone. And so that, I guess I'm going to emphasise this point again around make sure you get the patient contact details. And Jackie Yu has posted a really good comment here online as well around the fact that if you're going to order these troponins, you're going to do all these things, you need to know what your patient's up to and what their mobile phone number is. So always think about confirming that and making sure that you've got the best contact details.
And probably the crafty thing is, and can I have the mobile of your person that's with you?
Yes, the next of kin details is important, isn't it, really?
Because you're hoping that this person's not alone in their home, and they're usually not. Okay, so let's talk about anaphylaxis allergy. You've got the story, which triggers you. You've got the clinical presentation, but I'm just going to remind everyone that you do not have to have the full set of symptoms. So your classic anaphylaxis, you've got the airway swelling. You know that the airway swelling is happening because their voice sounds different. They talk like this because they're because they've got edema there. You've got the change in face with the facial edema. You've got the obvious skin rash, and they will complain of the itches and the hives. That's fine. Then you've got hypotension, which they're going to tell you they feel dizzy. They feel dizzy, particularly when they stand up. They may pick up their respiratory rate in response to that as well. You've got bronchospasm. Again, look at respiratory pattern. Are they talking in sentences, down to single words? What are they talking? Are they breathing rapidly, shallowly? And then lastly, you've got the gut effects, and they will tell you that they've got a cramping abdominal pain and they feel they're about to go both ends. So that's your full set. Any two of those constitutes anaphylaxis. Any two of those you use adrenaline. There is no point using an antihistamine by the time you've got beyond one symptom. And don't get trapped into the antihistamine will fix it routine, because it only stops one small component.
And often those patients have already tried, you know, if it has been a little bit before they've got on the phone, sometimes they do have their antihistamines at home, or they say, oh, I had a bottle of prednisolone and I popped a couple of pred tablets. And think,
which is lovely. They'll work in 4 hours time.
Yep. So in those sort of settings, I guess we're really thinking about ED. This is an ED presentation.
We need adrenaline. Hang on,
yes.
Hang on.
I'm jumping ahead here.
Can we get the adrenaline to the patient? Obviously, my standard patient should have an EpiPen. Somebody else in the family's got an EpiPen, because allergies do run in families, worth thinking about. So that's your first place I can get adrenaline from, in unusual places. The next place I can get adrenaline from is an ambulance, because they will come with that. So now ambulances arrive, they've given the adrenaline, and the patient's looking at you saying, I feel so much better. Do I have to go to the nasty ED and get infected? What's the answer?
Well, it's a tough one, isn't it? Generally, yes.
Yeah, you do. Well, you need them in a safe place of observation until you get past that second dip. The second dip is planned to happen about 4 to 6 hours. Can often be worse than the first dip, and it's often much more complex to deal with. That's what the steroid was for. So in a happy, perfect world, they took their steroid early, they had their adrenaline, they settle, and they don't need anything else. But I still tend to watch them till I get past that 6 hours. By the way, I tell them it's 12, and that way they feel they've won when they get out early. But what are we going to? How are we going to adapt that for this circumstance? Can you safely watch them anywhere other than ED?
I guess it's going to come down as well to family members and what capacity is of family members as well. They might say, oh, my wife's a nurse and she's happy to watch me and see how I go. And then thinking, do you then have an emergency management plan then you can activate, and she's got a plan that she knows what to do in that situation?
I'm not very convinced.
You're not convinced with that story?
No, I'm not.
Gosh, there we go.
I'm not very convinced
with
that. You see, my problem here is that why do we keep them in ED for the same time? We keep them in ED in case they actually block.
Yes.
And we actually have to intubate them in a hurry. And frankly, we need nothing short of a consultant anaesthetist or a consultant emergency physician on the end of that tube. Not a family member, thank you very much. Frankly, even if they happen to be a consultant ED physician, it's not fun tubing your own.
No, you wouldn't want to do that, would you?
So I think what we've talked about is the emergency life savings. Let's get the adrenaline to them, but it didn't let us off a period of observation. But it did allow us to be a bit more considered about how they got to ED without the panic, without the exposure, and maybe a bit of pre-warning. It's okay, this guy is now stable. He is going to sit straight in one bed in one short stay ward and not go all over the place. That might be a much slicker way to do it.
And I think that's a really good point as well, if your GP runs as well, if you are thinking of keeping the patient there, thinking about that risk of deterioration as well. And then, well, if you don't have the capacity to do that, or you're not connected in with an ED facility in your town, then it might be then thinking about, well, what is the options for this patient? Should they be sitting in your ED facility? And
the Hills practices get this a lot, because they get the hopper ant allergy, and a lot of folk are allergic to, and and the punters get a little bit casual with it. And I constantly get the phone call, do I really have to send them in? And the answer is yes, because they do get bad. All right, what else we got? Okay, next we're turning up with this CPR bit. So here we're talking about what happens if you are there, they've come to your practice, or you come across them in your minimal out and about that you're doing, and they arrest. Can I still resuscitate them? And this is, I'm hearing quite a lot of debate about this one. So let's think about what the risks are. The risks are that you might pick up COVID, and COVID is not nice. And if it doesn't kill you because you're not in the at-risk group, you might give it to someone who is in the at-risk group, your friend, your relative, your patient. So we don't want that. Definite nasty. Against that is, what is the actual chance of you picking it up? And downtown Adelaide at the moment, with our current COVID load that we know, the accurate figure seems to be about 3/5 of nothing, which is lovely. This is not the same as downtown New York or London. So I would say that there is a very definite risk of collecting it in New York and London, but I really doubt it for here. Now, okay, it doesn't matter. Let's play safe. Let's say I'm not going to start resuscitating unless I'm in full PPE, assuming that you've got the gowns, but that's the only price to pay. But it's not so. We know that time delay is survival. And I've said before that in the first few minutes, a 1 minute delay in defib is worth 10% survival. So you've got to be able to look the community in the eye and say, I didn't give my cardiac arrest patient the best chance because I was afraid I was going to catch a disease, and that's fine if the chances of catching that disease are sufficiently high enough. Now, here it gets a bit personal. Your own choices. I personally do not think that it is ethically warranted to delay or change your resuscitation process for the undiagnosed community load that we have at the moment. I do think that if I was in New York or London, I would have the opposite answer. And my question is, when should we switch? I don't think we've at any stage in Adelaide got to the point where we should do the switch. We've not got anywhere near it yet. But I don't know how many cases of undiagnosed community acquired COVID before we've got to actually start switching. But I can't ethically not resuscitate properly, because I think that's, and we were saying before, we do actually remember we did actually sign up to a wee small oath when we started this game. So that's an interesting point. And what I'm getting is a whole lot of people questioning what should I wear, not whether they should wear. And so we put up the next dot point. Think about meningitis. How many cases of meningitis do we see a year in Adelaide? 1, 2, 3, 4, something in that area. You know, it's a bad year if we get to 3 or 4 perhaps. But that's more than the COVIDs. And nobody's changing practice because of the risk of a meningitis. And there are unfortunate times where you do find yourself resuscitating a meningitis, and then you say, bugger, I wish I'd put on some PPE. And then you end up on antibiotics and things like that. And so it does occur, but it hasn't attracted nearly the interest. And I would say that in terms of frequency, there's not much between the two at the moment, I know. But it's just sort of making people think like that.
Yeah, it is a really interesting concept, isn't it? And then how this will change in the future as well with delivering CPR, and in terms of that need to put on PPE, because we know in the ICU and acute care setting that, you know, everyone is gowning before they even contemplate providing.
But that's a patient you know has got it, and you've got them in a negative pressure room, and you don't know that they've arrested unless you're with them, and if you're with them, you're dressed appropriately. Whereas the community, I mean, how many undiagnosed ones have we had? I think in the early days there were a couple that we couldn't quite trace, but all the others we knew exactly where they'd come from. We knew their travel history, we knew everything about them, and they were already under the microscope.
And it is really tough because exactly we've had a question come through that there isn't any treatment for COVID-19, is there? Whereas you can take those antibiotics for meningitis. There are other options you can do to try and protect yourself. And I guess it's that fear of the unknown, that fear of then infecting others, infecting family members, and how that makes you feel.
So you've got to be careful about dismissing the fear, because we're all of us human, and we're all of us driven by our fears and apprehensions. And I wouldn't want to force somebody into a place where they were made to be distressed and we did harm to them. So it's a sort of triple balancing act, ethically, isn't it?
It is. It's really tough. And the other thing as well, I remember at the early stages when we were talking about COVID and how this would impact on our CPR guidelines, there was some talk in the background about whether you would even administer CPR to people who had COVID-19 because of the risk of chest compressions aerosolizing out the COVID-19 in terms of that pressure and how that would impact on potential spread. So it is quite a frightening thing.
What's happened in Europe, where obviously they've got a much higher risk, is that the Resuscitation Council have advised that they would like people to do the early defibrillation and start CPR, while other folk got a chance to get properly dressed before doing the airway maneuvers, which they decide are the high risks. What the International Committee have done, they've done their best shot at a literature research, and there really isn't much to go on, to be honest, but it's extrapolation from previous episodes, is that defib, there is no evidence one way or the other that it's good or bad. Intubation and playing around with the airway is recognized as an aerosoling risky procedure. CPR, probably a little bit, but it's very, very weak. And so in Europe, they're still saying do it. What the Australian Resuscitation Council has said is we do not recommend you change for standard patients, but we do recommend for known infected or high probability of it, then you follow the guidelines and you start thinking about aerosol procedures and getting dressed. And it's a very interesting balance that we're in here. But then you've got your own personal ability to do it, because there's a lot of difference between somebody who is fit and well and somebody who themselves, the treating doctor or clinician, is on an immunosuppressant or something like that. And you think, whoa, that just changed it yet again. But I'm reassuring you that I think at the moment you shouldn't change your standard approach to resus, including mouth-to-mouth NB. It actually does give them a better chance if you're serious about giving them the best chance. But I've always said that if you can't bring yourself to do the mouth-to-mouth, then you just do the compressions.
And I think that is a really good point as well around the numbers that we have here in Australia versus the US as well.
But, you know, watch this space. We've all had a lovely weekend. Everyone's let their guard down and gone shopping. So we're either going to be feeling really smug in a few days' time or regretting it. I know, we'll find out.
Yes, and I mean, we've had a really good comment that came through around, chest compressions as well. You know, is that sufficient to be doing the chest compressions? I'll read out Jenny's question here. The patient can be resuscitated by chest compressions without breaths in mouth to mouth, which is still under current guidelines of willing and able to do mouth to mouth. Also less strong for breaths than it is for good quality chest compressions.
Okay, so the emphasis, doing nothing is worst. chest compressions is a whole lot better. Doing mouth to mouth of the ventilations as well as the chest compressions is a step up again. But if you cannot bring yourself to do the mouth to mouth, then chest compressions continuously, yes please. But they are not equivalent. There is good evidence that the breaths do add something, and as health professionals we should be giving them. The answer, of course, is that we should be crafty and carry a mask, which gets us out of that problem. That sort of drifts us onto the what the hell is PPE question.
Yes. The PPE question is a common one that comes up as well from our liaison in terms of, you know, what is a surgical mask? What's a level 1 versus level 2 versus a N95? So we have a bit of an understanding about the difference between surgical and N95, but now SA Health put out guidelines that say, you know, need to be level 2 masks for swabbing. So are you able to tell us a little bit about the difference between the different levels?
Look, all I can make out is that it depends a little bit on your circumstances, and there's some very cynical articles. I saw one just today about the Emperor's PPE coming from England, i.e. they will use what they've got. We know that a fit tested mask is the ideal, and a fit tested mask will have no leaks around the edge. And that's the first bit. The material that the mask is made of is the other thing. So the classic N95 duckbill mask has got a decent volume inside there, good area for it to cross across, and fits perfectly. I haven't actually been able to put one of those on for a very long time because I can't get hold of one where I work.
Common problem in general practice.
So now we're down to what's the best I can do. I think that the best mask fit you can do, and it's how well it fits to your face, is the best we're going to get in today's supply and demand situation. And so stick it on your face, suck in hard, and see whether the mask seems to stick to your face and come in and you don't get hisses around the edge. That's your crude fit testing. It's not done properly, but that's what we have to do if we're stuck. Gowns seem to be a good idea, but again, I laugh when I see all the people in the testing centres with their gowns on and their masks on and their long hair flowing down the front of their gowns, and you think, hang on, let's be consistent here. You either are or you're not. You know, if you're going to drag your hair across the patient and then inhale the virus off the hair, then what was the point of putting the gown on? Again, our colleagues in Europe are doing all sorts of things with plastic Macs and God knows what when they're getting desperate. I think that they do help.
And we know with scrubs as well, there's been a big move towards wearing scrubs as well, and just the normal general practice wear as well, and washing at a high 50 degrees plus wash cycle. Been some good evidence for that.
But again, there's evidence that viruses are small particles and are disrupted by soap. So yeah.
So there you go.
I don't know. It's. I think my point here is that there is no stock standard PPE, and you have to wear what the heck you can get. But just because it wasn't the official best one doesn't mean it won't do anything for you. We talked a bit about around the face. The only other thing up there that we were going to talk about was what's a negative pressure room.
Yes, I just wanted to touch on that a little bit because we talk a lot about in the guidelines negative pressure rooms for managing COVID. Well, of course, really have a negative pressure room in general practice, unless you can somehow work out your air conditioning to do some strange things.
Well, I mean, a negative pressure room is just simply a room where you suck air out of the room and expel it, so that if you open the door, airflow is going with you. So I guess you possibly could do that, but there are precious few of them actually in hospitals, proper negative pressure rooms. And so I think that I wouldn't get too carried away with the fact that we didn't have a perfect negative pressure room in general practice. You will be in very good company with all the people in ED. In fact, you'd probably be a lot better off because you'd be able to shut the door on that room and let it dry off, and then go and clean it later. Whereas ED, it's how many minutes do I have to leave it before I put the next body in there? So actually you'd be safer off in a general practice. But my comment here is one room, minimum number of people going into it, keep the door shut when you're not going in and out, and that's it. So if you are now contaminated in the room, don't bring everybody else in there to get contaminated too. Have them pass you stuff through the door. Use your intercom to say, will you please get me this, this, and this, and pass it to the door.
Yes. Confusing, isn't it? There's so many different things that are being told to do out there. I mean, we've just had a post come through. I know we're going a little bit over time as well now, but
sorry.
We both like to have a chat, so that's okay. But there's been a comment around the SA Health guidelines for GPs. The PPE is a bit inconsistent with national guidelines, but of course, across with healthcare workers. There's a comment here around that they advise N95P2 for aerosol generating procedures for hospital staff, and then surgical masks for GPs being adequate. And I mean, we've had this sort of back and forth conversation in SA Health around this, because we know that taking a swab is not typically an aerosol generating procedure. It's not classified as an aerosol generating procedure. But of course, when the patient sneezes and coughs, then you've just exposed yourself in a similar fashion. And it is quite difficult. I don't know if you want to comment on that at all, Hugh.
Well, all I can say is that it's until the patient sneezes or coughs, it's not an aerosol generating procedure, but you don't know that's going to happen. And that's why they are advising the heavy duty masks for the people doing the swab. But I noticed in Europe, when they've been desperate for masks, the advice has been take it, but stand to the side. We're stuck. My comment here is that no one will be surprised if you stick something up someone's nose, they sneeze. So expect it. So stand to the side. Can't do anything more. If I've got the better masks, I'm going to use them for that. That's the only aerosol generating procedure I'm going to be worried about in general practice, because I'm not intubating and I'm not sucking airways and things like that in general practice usually. All right. I guess we've done with this one, really.
Oh, yes, we did. I think we should talk a little bit just quickly about paediatrics.
Yeah, this is where I think we need to go. Scary people. The question we were pondering was whether you were able to do an adequate pediatric assessment down a phone/video link. The picture that we've got up there worries me. I've got a child that is too quiet to start with. I can see that. I've got this rather interesting rash on a very white face. So I've got enough information there just on that picture to say it worries me. And you wouldn't have had to have the clinician listening to the chest. So perhaps, I mean, we all get scared of kids, and if you don't get scared of kids, we were saying before, there's something wrong with you. But let's reassure ourselves a bit. You can actually do an awful lot of clinical examination from a distance. How does the child react to mum? Are they following with their eyes? Are they neurologically alert? Have a look at the skin color. You can see that quite nicely. Look for respiratory rate. You can see that one. And if you've got a kid well rugged up and you can see them breathing with their normal kiddie clothes on, you've got a problem. Look for nasal flaring. Listen for grunting. Above all, listen to mum. She knows that they've changed. Capillary return. You can do a capillary return remotely. Get them to push on the forehead, not the periphery, because they could have cold hands. Push on the forehead or the nose, count 5, take it off, and you can watch it. You don't have to have anybody count for you. So I've actually got a cardiovascular and respiratory assessment quite nicely there. I've got a neurological one by how they're moving. So I think that the assessment skills, in fact, work very well remotely. The treatment stuff is trickier because all that most households will have is kiddie Panadol or kiddie Nurofen. There's nothing much else open to you, but then you ask yourself, well, what actually do I need? Because if it's anything much beyond that, then this is one that it's worthwhile bringing in, making somebody else's problem. And then now we have the discussion about what's the risks of bringing this child in a hospital versus the benefits. And hitherto, we have said that children do better. And I know there are some alarming stories coming out just recently, but I think they are the exception, not the rule. So I would still bring the child in if they are failing their cardiovascular, neurological, or respiratory assessment that I've done down the phone. So that's where I'd go. So any other ones you look for?
Well, I guess the other thing is around asthma as well. So that's probably the other thing. We haven't really talked a lot about asthma management. We talked about this before we started the webinar, as around, you know, Ventolin usage as well. And I guess we're thinking about
the bigger child. And
I guess I'm sort of thinking about the, you know, the slightly, older child, thinking about the 5 or the 6-year-old who's, you know, has had an upper respiratory tract infection, not COVID, and then we are concerned about asthma in that child, and then what to do in that situation.
So there's nothing to stop you using quite a lot of Ventolin. The New Zealanders and the Australians don't agree whether it's 4 or 5 blasts into a spacer. There's nothing to stop you improvising a spacer if you haven't got one. Plastic bottle, cut a little hole in the bottom, shove the puffer into that, and the child sucks out of the lid where there's no sharp ends. That's not a bad spacer. Spacer given Ventolin beats puffer Ventolin hands down. We all know that lesson. So you can start improvising. It doesn't have to be that patient's Ventolin either. It doesn't have to be Ventolin. It can be any blue colored puffer, because if we all know that they're the treating ones. So has anybody in the neighborhood got one? And you start to do that, and you usually can find one. Load it up into a bottle to do your pretend spacer, that they haven't got a nice spacer, and you're halfway to treating them. Why do I want to do that? Because I've done a respiratory assessment, I've watched their respiratory rate, effort, and picked up their tachypneic. They can't speak to me in full sentences. They're down to shorts or yes, no's. By the time you're down to single words, then it's stacked spacers. And if that doesn't get you out of jail very, very quickly, it's hospital.
And it's an interesting point as well that, so Jackie's posted this around, you know, we talked about aerosolizing procedures and sort of not doing spirometry in general practice. This was certainly something that was mentioned right at the very beginning. Is there any issue at all with Ventolin spaces with COVID risk, particularly if someone we didn't know that their status was and they came in or they had those sort of respiratory symptoms?
Not really, because if you think about it, it was during the SARS epidemic, in fact, that we pointed out that spacers were so much safer than nebulizers. So it's the nebulizer I don't like, because I've got this mist floating in and out. The spacer, the big droplets end up on the spacer. The smaller droplets, which are about 7 to 10 micron size, go down the lungs and stick there. And then so you've just got a few superfine droplets, the 5 micron and under, which are going to be expelled. That's a very small amount compared to a cough or anything else. So I would say spacer is a pretty safe thing to be doing.
Thanks, Hugh, for that. Wonderful. So I think we've come to the end of our time. Thank you so much for sticking with us. We've had a large number of participants tonight, which is fantastic, and we're so grateful to have you with us here. It's been so wonderful to be able to hear your expertise around emergency presentations. I know we've had a bit of a back and forth discussion about what to do with those patients who do present with their troponins as well, and, you know, do you do the troponin in general practice, in an urban general practice, and you sit on it for hours, or do you just send them straight into ED? So we've had some really interesting discussions around that, and I think it really is weighing up the clinical benefits and the risks for your situation and how that works for you and your knowledge of the patient and your concerns. So thank you so much to the RACGP and for Angelica here tonight for hosting us, for listening online. This will be available and it will be uploaded, and we'll communicate that out. And just one final plug, I just want to say, if you are on Facebook, don't forget to think about joining the RACGP SANT Facebook page as well. We're really keen to make that a collaborative space so that everyone who's comfortable will be able to post their questions, and we can get some really good interaction happening between the RACGP and with GPs across the state. So thank you so much for joining us tonight.